with 50% of the population being women and 100% of women going through the menopause at some stage, that is going to be a huge, enormous amount of women that will be presenting to primary care. And we felt that we needed to find a different way to perhaps support women by trying to increase our capacity with the rising demand. Also, as a primary care network, we were encouraged to look at health inequality work. We felt that this would be really important in regards to improving access for women with menopausal symptoms. And within that cohort, there would be women who come from deprived backgrounds or from ethnic minority backgrounds, where we wanted to try and reach out and support people in a different way. We also felt that, particularly with the changes in the new contract for general practice, which is going to be very challenging for us in April if it goes ahead, is that when we don't have any appointments, we do need to look at other ways of signposting people for support. And we felt that group consultations would build capacity within the system to effectively diagnose and offer more holistic management to women. If we look at the workforce in particular, we look at the current model of general practice, which is 10 to 15-minute appointment time. It's not ideal for long-term conditions and for the menopause, because ideally you need longer to discuss, well, to come up with an accurate diagnosis, to come up with an accurate management plan, and also then to look at the holistic needs and to adapt a more personalised care support. And also, particularly since the pandemic, we feel that the model's quite relentless and there's a lot of high pressure within the system where you feel as though you're on a treadmill, you're doing 10 to 15-minute appointments and you don't seem to have time or space or take a breath, which obviously impacts on job satisfaction and personal well-being. And so this is an opportunity for us to take stock and think, can we support and put things into our system to support the workforce in being able to feel happier and more in control at work. The other thing to bear in mind, particularly around workforce, is if we're to look at flexible working, and also from a primary care network perspective, we've had huge issues around estates. We've employed a lot of additional roles and we're finding it extremely difficult to try and house people, because as we're employing more people, we need more space, and that has been a huge pressure point within our primary care network setting. And so group consultation, particularly virtual group consultation, has enabled us to think, well, perhaps we can look at training more people up to do virtual group consultations so that we could offer the exact same appointments or support, but in a virtual setting, which means that you can do it in the evenings, you can do it from home or from another setting, which enables us to still create the capacity that's needed for the rising demand in primary care. And lastly, there does seem to be, from a strategic point of view, there's a lot around prevention and personalised care, which is brilliant, but it needs more time, and group consultations enables that to happen. Next slide. So Rasheen's now going to go through the group consultation model.
So as my role of technical support facilitator for the Menopause Physio Group consultations, my primary aim is to make everyone feel at ease and introduce the session while simultaneously being on hand to check and deal with IT and security issues. By introducing the premise of the group, which is a support-led group for women suffering from peri and menopausal symptoms with a genuine, tangible medical outcome, we are creating a safe space for women to speak and share their stories, weaved together with the clinical expertise of a menopause GP to inform and empower women to medically recognise how and why the changes are happening in their bodies. As this is a shared medical appointment, we do lots of consent and confidentiality checks prior to the group starting to ensure the right people are in the group and that privacy is respected at all times. We make it clear to participants attending that a VGC is completely voluntary and you can change from a VGC appointment to another appointment at any time. In our menopause VGCs, we have clear roles involved, which we touched on earlier. So the healthcare professional, the technical facilitator, and the menopause coordinator. So in our PCN, it just so happens that these are 3 different people because this is what works for us. However, in some cases, the coordinator and the technical facilitator could be the same person, which I feel like we will be trialling in the future when we're expanding our VGCs to include pre-diabetes and health and well-being. Next slide, please. So this is what our results board would typically look like. Obviously, I've taken names out. So by confirming who is in the session, we make sure that only data from participants in the group are shown to uphold our patients' confidentiality. So that is such an important part of a VGC. So if a participant hasn't joined or they've joined and become overwhelmed and left, you have to be monitoring that because you cannot be sharing their medical outcomes with anyone else. These results are generated from the symptom tracker that the women have previously filled out on our website to monitor their menopausal symptoms. For me, this is one of the most effective tools of a shared VGC, as women can compare against each other, as in a normal face-to-face GP appointment, you only are presented with your own clinical results. Another way I feel the VGC is more constructive than a normal GP appointment is that some questions some women either may forget to ask or are too embarrassed to, but having a whole mix of different personalities and symptoms, an open, honest conversation about the menopause is encouraged and explored. Next slide, please. So this is our topic board. So before we get to this stage, everyone would have introduced themselves and they would have discussed their journey with the menopause. So 9 times out of 10, all of these are mentioned from the women anyway. So they're wanting to know about these symptoms, and then Dr. Jackson kind of goes through them all. So this is when I pass over to Dr. Jackson and she discusses the symptoms that the women have already started discussing and gives a clinical explanation of each symptom and suggests ways to alleviate them, such as HRT medication, the holistic route of health and wellbeing management, and better sleep hygiene. Dr. Jackson offers a very realistic outcome and explains to these women that there is not a one route fits all, as the menopause is such a personal pathway with no magic pill to cure everything. Furthermore, the results board goes more in depth than any 10 to 15-minute GP appointment ever could and leaves the women feeling knowledgeable and empowered to make decisions about their own menopause pathway. After the topic board, the doctor does a one-to-one with each participant where they are offered HRT assessment with a menopause GP if this is a viable option, a health and wellbeing intervention which includes exercise tips and nutrition, an over 40s NHS health check if they haven't had one with their work, and reminds the group about keeping up to date with all cancer screenings, which is obviously pertinent if you're going to go on HRT. We are finding in most cases all women opt for all 3. And then our menopause coordinator contacts them to book them in for a session which suits them. So they feel like they're getting a tailored, specialised service from the NHS. They do not need to ring in the morning and join the queue at 8 AM for an appointment. Next slide, please.
Thanks, Roisin. So we've been doing this now for 4 months. We do a virtual group consultation every other Wednesday, and we're now starting to see the outcomes of the interventions that we've started. What we found is that it definitely enhances the patient experience. So as Roisin has just said, we have created better access arrangements for women presenting with perimenopause, menopause. If they still want their one-on-one, they ring at 8, and if they can get an appointment, they will get their one-on-one. But more often than not, if the appointments have gone, our receptionist will offer them a virtual group consultation in which they will fill out a symptom tracker, which is on our website. Once we receive the symptom tracker, the care coordinator gets involved and they will be booked on to the group consultation. What they found is that they have more time to understand their condition and understand which route they go down in terms of management. And it's very clear they get a better understanding of their condition so that they understand why it's happening and what management plan is more appropriate for them. So it's a really tailored approach, an individualised approach to each person. And what we have found is when people do leave the group consult, they're already activated, they're already thinking, you know what, I think I'm going to do X, Y, and Z to try and improve my symptoms, which is really great because it's very, very difficult to do that in a 10 or 15-minute appointment. From a clinician experience, we find that it creates a rich learning environment, and I find it's a rich learning environment from just observing the group consultation. So for me, I've just learned a lot about how it impacts women. You know, you can get mild to moderate to severe, and I hadn't realised how severe symptoms can impact on women and how it's so important that we do need to try and manage menopause more proactively. It also creates a learning environment within the PCN. So we're finding that it's a great environment to improve consultation skills. It's a great environment to learn from others. And what we're now doing is trying to look at a programme where we try and upskill everybody to be able to do group consultations going forward. It gives more time to patients. So as a clinician, you do feel more satisfied. You know, after group consult, it does make you feel as though you've made a difference, where sometimes when you're rushed and you've got a 10-15-minute appointment, sometimes you can't give the patient enough time, which can be demoralising at times. And there is evidence now coming out that it can support retention. We're finding that virtual group consultations in particular are becoming popular because it does enable flexibility, and as I say, it's a real solution for estates pressures. As regards to clinical outcomes, we're finding that if you look at research from a menopause perspective, we find that women attend many appointments before they get an accurate diagnosis. We know that some women get misdiagnosed and are either diagnosed with anxiety, depression, or fibromyalgia, or or not even offered HRT. So we do know that from doing this, that the clinical outcomes of a more accurate diagnosis, a speedier diagnosis, and a holistic approach. So it's not just about HRT, it's about looking at all the other healthy lifestyle initiatives that can be as effective as HRT to improve people's well-being, but also from a preventative perspective in terms of trying to reduce cardiovascular risk, diabetes risk, and osteoporosis risk down the line. We are finding that from a menopause perspective, it's starting to reduce our clinical backlog. So we're finding now that we can effectively offer women appointments within 2 to 4 weeks, depending on if there has been something on the TV. So we do find that if there's a big campaign on, for instance, the recent HRT prescription exemption certificate that you can get, where you can pay upfront, I think it's like £20 for a whole 12 months. We found that suddenly there was a massive influx of women ringing in asking about HRT. So it did enable us to manage peaks in demand around menopause queries. And the other big outcome for us was it enabled us to develop a whole menopause pathway for our primary care network. So we have 4 practices serving 45,000 patients. And so what we've now got is a standardised service where we offer anybody who presents with perimenopause symptoms a virtual group consultation. And as a result, we weaved in within a few months the health checks and the health and wellbeing initiatives to try and weave in the prevention agenda to reduce things such as cardiovascular disease, osteoporosis. Next slide, please. So the challenges and lessons learned. So initially, if you weave in, getting people on board across your primary care network, if you weave in the training and then getting the group consultations set up and regimented into, say, every 2 weeks, it's initially very time consuming to create a sustainable model. So generally speaking, we're looking at 6 to 8 months to get embedded. We've been doing it regularly for 4 months now, and we now, Rasheen and myself, we've got our sort of system, and we've got quicker and more confident as time has gone on. And we feel that now we're starting to get the benefits from doing group consultations. We know that workforce can be a big challenge. We had a health and wellbeing coach who we initially trained up, who was excellent at group consultations, and she was doing them around health and wellbeing initiatives and helping people with low level anxiety and mental health problems. But unfortunately, she left. And so that left us with a big gap, and then we had to spend time recruiting and training up another person. So all I would say is that you need to probably train up quite a few people, so that if somebody leaves, they don't leave a massive gap where you're then having to pause the group consultations while you're getting other people trained up. The one thing we're now working on is trying to increase the awareness of the value of group consultations within our patient population, because it's still pretty evident at the moment now. When we start a group consultation, you can see that 50% of the participants are quite happy and 50% of the patients are a bit unsure of the situation, and they're there because they're desperate to get some support. But over the hour that we have with them, you can see that they become more relaxed, and by the time we finish, you can tell, with their expressions and how they feel, that they've got what they've needed. And it would be really useful for us to try and get the message out there that group consultations are as effective, if not better, than one-on-one group consultations for certain conditions. We do invite extra patients to offset DNAs. We still get people who don't turn up. So generally speaking, we have a clinic of 12 people booked in. And generally speaking, we may have 1 or 2 people that don't turn up. So I then end up having usually about 10 in the group consultation, which is very manageable. Having done group consultations for a while now, it does highlight a lot around patients who don't really understand their condition, because, as I say, that there's a time limit in normal consultations. Patients don't take in as much information, and also you haven't got time to give them all the information. And so generally speaking, it's quite evident that doing group consultations, people do get a better understanding of what their condition is, and it gives them the knowledge and it empowers self-management, which we've always struggled in the past. But this is definitely something that we are going to look at in regards to other long-term conditions going forward. Another thing we've struggled in the past is it's a mechanism for peer support groups. And what I found in group consultations, and it's really good to see, is when, for example, when we're talking about the menopause, and some patients will say, oh, I'm not sure about the Mirena coil, I've heard really bad things about it. And we have had other patients then in the same consultation say, well, actually, I've had one and it's been absolutely amazing. And sometimes information coming from patients rather than the clinician can be more powerful. And so the peer support is an important factor, group consultations. Making personalised care easier is another great lesson that we've learned, and it fits so well with our additional roles. And this is why, as a PCN, from April, we are going to explore the majority of our additional roles being trained up to do a lot of our long-term condition management to support primary care going forward. And as I say, it's so easily transferable to other conditions such as pre-diabetes, diabetes, COPD, and we're looking at uncontrolled hypertension as well going forward. And we're just going to finish on our last slide now, and Roisin will take you through that, as Roisin is the one that basically gets all the feedback from our patients after each group consultation, so that we know hopefully we're on the right path and to find other ways of improving what we're doing around group consultations.
Thanks, Alison. Roisin, I'm really conscious of the time, so if we could keep this slide fairly brief, that would be great. Thank you.
Of course. So
thanks.
yeah, if you can read your slide, just say that it's been an overwhelming success, and it's just been really proud to work with it, really, and feel like we're really helping these women. It's been great, to be honest.
Lovely. I'll just leave that slide up for a sec. Thanks. Thanks, Roisin. Thanks, Alison. That's great.
Yeah, hi everyone. So I'm coming at this from a kind of a workforce perspective. So I'm the health and wellbeing as well as the EDI, so Equality, Diversity, Inclusion and Belonging Project Manager for BLMK, so for Bedford, Luton and Milton Keynes. Can we go on to the next slide, please? So obviously this has come at a really wonderful time in terms of it being International Women's Day, and just to give you a little bit of a background of why we set up the sessions and linking it with today. So as an area, champion kind of equity in the workplace is a real priority for us. And as many of us know, women make up the majority of the NHS workforce. So here in BLMK, that sits at about just above 70% of our workforce are female. And they're kind of the backbone, obviously, of the care industry, but that's both at work and at home. So women are most likely to perform caring responsibilities for their children and parents. And if you've seen recently, there's a load of reports that have come out about this. You know, I think it was the Centre for Progressive Policy came out and said that women perform something like 23.2 billion hours of unpaid childcare and care for parents a year. So when you add on top of that the changes in health, whether that be periods, pregnancy, loss or menopause, we need to make sure that we're supporting women in the workplace. And the kind of the irony and the tragedy of this is that women tend to reach their career peaks as menopause strikes as well. So we decided that we really need to champion and support women in our workforce, further than just kind of signposting to general support resources. Next slide, please. So that's when we made the decision to link with Georgina and Helen and the team, who gave us a really comprehensive idea of what a menopause circle was and how it could benefit our staff, giving us some examples of other areas, sort of flagship areas that had run it for themselves. And once we decided that this was the route we wanted to go down, the next step was for us to recruit a team of clinicians that had an interest or specialism in the menopause. So the way we did this, so I worked for a training hub, which you may or may not have heard of as a kind of setup. It's quite unique, and one of the really beneficial features of it is that all project managers like myself are supported by a team of wonderful clinical workforce leads. And these workforce leads come from a variety of backgrounds. We have pharmacists, GPs, nurses, physios, we have optometrists, we have dentists, we have all sorts, and they are able to kind of provide us expertise and insights as practicing clinicians. So it gave us a little bit of a head start with recruiting people on, because we were already aware throughout our practices of who we were going to approach for a set of clinicians to help support with the sessions. And as was mentioned before, we have tried to recruit quite a big group of clinicians as well, because as the nature of work, people move on, people have competing priorities. So we have quite a big list of people. They're primarily GP nurses and GPs at the moment, who run these sessions for us. So far, they have provided really brilliant insight for the circles and given really fantastic advice that has empowered our attendees to have really purposeful conversations with their healthcare professionals or try something new themselves. So we've been really fortunate with that group that we've managed to onboard as clinical experts. Next slide, please. So promoting the circles out. So we promote them, like I say, to our staff groups. and we promote it throughout. So I primarily support primary care, but I also work for the kind of the ICB and ICS, the wider systems as well. So we promote it out really widely to any people, any women that we think will benefit. Two main suggestions I would have if you are looking to promote this to workforce is, number one, don't assume that people know what you're talking about, and number two, kind of 7 times a charm. So that real kind of active and engaging promotion is key with the circles, because it's a really unique offer, and we found that a lot of people weren't actually aware of what it was. We were luckily, as most people in primary care are aware of what a group consultation setup is, but like I say, definitely don't take this for granted and be really clear about what the offer is when you're promoting it. And like I say, the second offer, as with all offers and resources, you need to promote as much as you can. So I utilise all kind of forms of communications. You can see here is one of the tweets that go out to people. We email people. I attend as many forums as I can for our staff briefings, and just really shout about the offer. And like I say, keep going with this. And I would say this is the case either with patients or with staff. You know, it takes several times of hearing about things before people to really begin to resonate with people and to know what you're kind of talking about. So really keep going with that kind of high level active promotion of the circles. Next slide, please. So setting up an onboarding. So for ourselves, we decided to use Eventbrite as a way of collecting attendance and data. The reason we decided to use this is that it's really user friendly for people to use. It's a very obvious way of using it. Even if you're not very tech savvy, you can do it on a computer or easily on a phone. People are also able to use their personal emails, and that's something we found really important when supporting our staff with, you know, well-being and health. It's often very personal to them, and they might not want to be putting on their work or professional emails. So Eventbrite allows you to do that. It doesn't kind of block any emails that aren't NHS. And it's really easy to collect the kind of required data and to collate that. And we also use things like Canva to make our posters as well. So really utilising the tech that we have to push this out far and wide. And then on the next slide, you can see what one of our Eventbrite forms looks like, and this is what the user sees. So an important part of the menopause circles before is that you're collecting information on their date of birth, the location, and that's just to check that people are okay, whether they're taking HRT. So again, the clinician has an idea of who is in the room and what stage they're at. And then we also ask them to provide a password. And I should have mentioned at the start, all of our sessions are virtual, just because of the nature of we're kind of offering this across very, very large patch. So it's not really feasible to do it in person. It's maybe something we could look at in the future. So when people dial on, we ask them to give us a password. So it's really easy for people to input the data, and then it's really easy for me to take it off and put it into a format that we need by using Eventbrite. And just to say as well, so after we've inputted and used the data, we always delete all copies of everything that people have sent over as well, because it's potentially sensitive information. Next slide, please. So my final slide here is just some of the lessons learned. So we're still pretty new into running these sessions. I think there's most of the stuff we carry on, and there's, like I say, there's a couple of things that we're going to do differently moving forward. So one of the things I would recommend is having the clinician on the call from the very beginning, and them just being camera and mic off in the kind of corner, but they're able to hear that conversation from the start, that the facilitator, either myself or my clinical lead, when we're facilitating that initial conversation. Because when you're doing it, the clinician has an option to either come on 30 minutes in or sit in the call, but I would really recommend that they do that from the beginning, because they hear the kind of nuances of the conversations that are going on before they kind of come into that call, and they're just slightly better informed. And we've done that with all of our sessions, and it's worked really well. Definitely carry on using Eventbrite and Teams. So Teams is a really great format to use. It's very safe. People can't really hack into it. You can lock the meetings once people are in. And again, the same with Eventbrite. It's kind of a safe way to store data, and it's easy to delete that off. And another one I'd say is really important is to have a set of resources to share at the end. We're very clear with our circles that once we're done, we're kind of done, unless we think that people are in kind of immediate danger to themselves or others, and then we would follow that up. But we kind of enter it in as, you know, we're all adults in a room. You have to kind of hold what you're going to give to people, the information that you're going to give. You have to be responsible for that. But I think it is really good if you can do something to kind of follow that up at the end. We have something called Peppy, which is a menopause app, which we offer out to our staff, which is a really fantastic service. And that offers support at each stage of people's menopause journey. So it's really nice to be able to offer that to people at the end, as well as other bits of information and resources that we can signpost people to. Going forward, I'd say the longer lead time, the better. Working in primary care, as many of you be aware, you know, your rotas they're up 6 to 8 weeks in advance. So if we're wanting people to take that kind of hour and a half out to support themselves, we have to make sure we're giving them enough time to be able to kind of book out their clinics or whatever they need to do. And that being said, that kind of takes me on to my next point as well. I think offering different times for each session, and I think I heard Helen say about somebody running a morning session soon, and I think that's something we've really learned. Instead of doing it during the day, we're going to run them primarily in the evening, because after our other wellbeing sessions that we've run, the bookings just fly up when we pop them in the evening, because again, people just often do not have time to take them out of their day, or potentially they're sharing things that they don't want to be sharing if they're in an open office or in a room where people could potentially walk in. So we might look at doing some early morning sessions, but at the moment we're doing it in the evening from 7 till 7:30 till 9. Because people are in kind of their own environment, they're in a secure room, and it often facilitates a better conversation. So that's kind of all I had to say. I just wanted to give some feedback we've had, as well as some quotes from the last one we had, that it was a really transformative session. Somebody else said, I feel empowered and heard. And again, similar to what Helen did at the start, we always do the thermometer. And we had one colleague that went from 0 to 10 over the course of one session as well. And she felt that it was a very emotional session. She felt really empowered to then go and have those conversations with her healthcare professional herself and get the help that she needed.